Put one more Tuesday in, which would be this Tuesday. And if anybody has any conflict with regards to exam, it'll be basically the same exam with some adjustments, so that you're not exactly taking the same exam, but that you'll have the opportunity, you'll have the opportunity to make it up, and on an individual basis, I'll set up that schedule. In regards to, I'm going to put a blueprint out over the weekend. I will also look to, the fact is that the review is what you really need to listen to, and I'll make sure that that's recorded so that you have, a good overview in terms of what the exam is going to cover. So I'll just leave that alone, and if you get, if you study from that review, you should do fine. Okay, the purpose is for us to make sure that you get through the semester, but also obviously to make sure that you get the information that you need. So if anybody has any issues with the schedule, the updated schedule that I put out, please let me know. And remember that the idea is flexibility. Now, there was some emails late last night that was sent to the faculty saying that they didn't want to continue classes through, like tomorrow, or, during, some of the days that are listed there. If anybody has a problem, just please let me know, and I'll make arrangements that you'll get the information accordingly. But how I understood it from you guys is that you want to follow and just keep going so that you get through the semester.
Yes.
Is that correct?
Correct.
Yes.
Okay.
My only issue is the first exam. I see that the other ones are on Thursdays. I might.
Yeah, no, I'm going to have a second exam, and I'll reschedule that for you. What I'll do is offline, I'll send out an email saying who can't make that first exam, and I will set something else up for you. And I'll work together with whoever can't make that first exam to have a collaborative date so that you can take it. Okay?
Thank you.
All right. So everybody, we're going to be flexible here. And I'm thinking, I'm talking to my colleagues, at H&H, at Health and Hospitals, and, maybe a little later on, we can work something out with regards to you guys volunteering. All right. And take it from there and use that towards clinical time. You may not necessarily be at the bedside per se, but you'll play a role in terms of helping out, but they have to tell me it's okay. All right, so to take it from there, because they have had a big issue with PPEs, as you've probably seen, personal protective equipment, as you've probably seen on on the media, and in regards to that, we want to make sure that everybody's safe and everybody has the appropriate accoutrements necessary to take care of these patients. Just as a little aside, I've gotten some emails from some of you about face masks. As such, the surgical face mask basically protects the patient from you, all right? Not you from the patient, because it doesn't provide a tight seal. So those face masks that have the elastic around the ears, that's a surgical mask. And very often those masks get moist quite quickly. So it protects other people from you. So if, let's say, you're taking care of an elderly grandparent at home, somebody who's, you're living same quarters with somebody who is ill like that, has multiple chronic condition issues, maybe in close I just had, yeah. If you're in close contact, you would wear that surgical mask, all right? The N95 is something that you need to be fitted for, and that has a tight seal around your face. As long as you don't have a beard, or your beard is such that it's underneath that face mask to provide you with a tight seal. That face mask is good for hours. Okay, so you could wear that for basically a full shift. Okay. Problems with that face mask is that you have to look to, does the person have any pre-existing respiratory issues like asthma? Okay, so the length of time that you could keep that mask on somehow, diminishes. All right. When you're out in the environment, you want to keep 6 feet away from people. You want to make sure that when you touch things, that you have some type of barrier between what you're touching. You want to cleanse the surface of areas that you're in contact with, because the coronavirus can survive 40 to 72 hours on a surface. Excuse me. And basically, you want to keep distance. That whole idea of social distancing is vitally important because of the transmission issue. And the 6 feet is actually past the distance, but it's important to be at least 6 feet, because then you're definitely safe with regards to distancing. And when you're outside, the concentration of any of the virus is such that it's so limited that it wouldn't infect people as long as you're in a well-ventilated area. So out in the environment, out in the street, that be the case. But inside, you want to make sure that there's good ventilation as well. Okay. So if anybody has any other questions, just please offline, send them to me. And I'll send you some information that I've gotten regarding an update. The actual virus itself is causing damage, interstitial lung damage, and takes anywhere, and if somebody's on a ventilator, that's also going to be problematic for the individual, because obviously their condition has deteriorated significantly, and the longer they stay on, all right, so that leads us to the lecture that we're going to have today, which is basically talking about ventilators. And I'm going to give you more information than you might need, but it's important that you have a sense of what's going on in terms of the ventilated patient. Because remember, not just for the ventilator, but with any piece of equipment that is left at the bedside of the patient and nobody else is there to monitor, you, the registered nurse, are responsible for. Okay? So what you may have seen in the hospital is if somebody is getting hemodialysis, you're seeing that there's a hemodialysis nurse there, right? But the reality is that with the ventilator, you don't have a respiratory therapist doing one-to-one, so that you have to have some knowledge of the ventilator because you're managing the patient. Okay, so in terms of the ventilator, we're looking at
Excuse me, Professor, do you have the marker slides available so we can see better?
Let me see if I can do that. Okay, I don't want to promise you that, but let me see. What keeps coming up is let me see. Let me see if this works. Hold on. Can you see that one? Can you see that? can,
It's still the four slides and
yeah,
on one.
but can you see that one? Can you see this one?
I can see it, but I was saying like if it was available as a slideshow, like how you did it last time. But if
No,
it's-
I brought up the slideshow, but I don't see that,
The professor's using a workbook, so that's why it's like this.
Yesterday's slideshow, she didn't have all the slides.
can you see it now? Can you see it?
Guys, even if she did a slideshow with this, it would still be 4 slides per page.
Because that's how the
That's how the workbook is set up.
Yep.
But
This is fine. I can see it.
Can see. Can you see actual cells? I put up the slide. Apparently. It's not letting me.
Yeah, it's fine.
Okay.
You can just go ahead with the.
Can you see it now? Can you?
Yes.
All right. Can you see the full slides now?
Yep.
Yep. Okay. It's getting to that point. So anyway, so what we stopped today was we stopped with the actual different types of ventilators. And we talked about the 2 types generically of ventilators, and that was negative pressure and positive pressure. Negative pressure ventilators basically exert pressure external to the patient so that you basically can assist in terms of the muscular movement to bring in the air, to bring in the environment gas, so that there's no artificial airway with a negative pressure ventilator. And so that you can't, basically the only thing that you're treating with regards to somebody with a negative pressure ventilator is that they've lost muscular function. Now, that's why excuse me, the negative pressure ventilators were used with polio patients way back when, and the machine that was primarily used was something known as, you know, it's a colloquial, the iron lung. But basically, here we go. But basically, the negative pressure ventilator is going to only support if you have a weakness, so in muscles. Now this was the old lung. They have device here known as Caress, which surround the individual and subsequently can also provide that negative pressure with a tight seal around the thoracic cavity. But if you have specific diseased lung tissue that is internal to the patient, a negative pressure ventilator is not going to be useful. So in this crisis, as we're seeing it, the damage to the lungs is internal. So really a negative pressure ventilator is not going to help. So what you see utilized here, excuse me, is most commonly what you're going to see 99% of the time, a positive pressure ventilator. And what a positive pressure ventilator does, it's called positive, it's pushing gas into the lung. It's not, it's obviously doing so by a positive framework. Now, the problem with some of the, you know, more about complications in a little bit, but part of the problems with positive pressure ventilation is that you are going against the normal physiology that exists within the thoracic cavity. Okay, so besides the lungs, besides the lungs, What also is there is obviously your cardiovascular system, so that that negative pressure also helps with venous return. Now, when you're on a ventilator, there's going to be a slight compromise in terms of venous return, but the benefits of utilizing this type of ventilator generally far outweighs some of the complications that you might see. And also, what you also have to consider is that when they're on a positive pressure ventilator, you have to remember that pressure goes the path of least resistance. So what primarily happens then is that gas goes to the non-affected lung instead of going to the lung that's affected, because it's going to go where there's least resistance. So it's going to go to the lung that doesn't have necessarily the damage, so that other settings are going to kick in to help deal with that in its presentation. So, we'll look to that accordingly. But there are some entities that hit the lungs in terms of, from a more generalist framework, that are bilateral in nature, like ARDS, so that this concept really doesn't apply. Now, the modes of ventilation are: how are you delivering the breaths, the ventilated breaths? These machines, and you hear them, it's interesting that the governor actually uses the right term. These are ventilators, all right? These are not respirators. Respirators guarantee delivery of oxygen to the cellular level, so that the only machines that we have out there that are truly, by definition, a respirator are bypass machines that you have when the patient is having open heart surgery, or ECMO machines, which is basically a bypass machine, but is utilized to, once again, deal with cardiovascular function and rest the heart, so to speak. So that when you're looking at machines that are just dealing with ventilation, you're looking at and the process there get into the lungs to ventilate. So these machines are ventilators. Now, how is gas delivered by the machine to the lungs? Well, one way is by assist control. And assist control is basically takes away the work of the lungs in terms of initiating a breath, okay? If the patient has a little bit of effort to start to take a breath, the machine in assist control will complete it. So if the patient has a negative pressure, a negative inspiratory pressure of -2 centimeters of water, generally speaking, the machine says, oh, patient's taking a breath. The machine's going to kick in and do the work and complete the breath accordingly. So assist control rest. Other thing I need to say, which I should have said in the very beginning, is anybody who is acutely placed on a ventilator, needs to be sedated, all right? Because you weren't born with an endotracheal tube in your lungs hooked up to a ventilator. So your body is going to have some kind of fight against it. So patients who are acutely, not chronically, but acutely placed on a ventilator need to be sedated. Okay, and some medications that are used for sedation, most commonly it's fentanyl. You may see propofol, Deprivan. You may have heard about propofol, Deprivan, sadly, with the incident with Michael Jackson. But this is a drug that should only be used under the direction of those people that are actually trained to use the drug. is actually a regulation that says the only primary care providers that have the power or the authority to order propofol in particular, and this was before Michael Jackson actually, are those people that are in critical care and anesthesia. And only critical care nurses can monitor the continuous administration of propofol because they've been trained in a certain way with regards to understanding the concept of sedation as well as conscious sedation. Okay. One other thing about propofol is that it's milky in appearance, which means, you know, it has a lipid consistency, so that if somebody is on propofol for a couple of 2 or 3 days, for example, you have to consider that in your calorie count, so that the dietitian needs to know and take notice of that as well. Fentanyl is, going back to fentanyl, it's an opioid, and you know, and it when you stop the fentanyl, it's going to take a little while to dissipate because of its half-life. Whereas propofol, its half-life is immediate. You turn it on, the person's sedated. You turn it off, you don't have the effects of sedation anymore. It's almost instantaneous. So once again, any patient who's acutely on a ventilator needs to be sedated so that the machine can do the work that it's intended to do. Now, assist control picks up that I'm sorry?
Can you go over your notes in regards to assist control? Because I wasn't able to pick up everything that you said about it. You were going in and out.
Assist control is when the machine does the work of ventilating for the patient, so that the patient, the machine picks up the fact that the patient is starting a breath, okay, starting to take a breath, but excuse me, but the machine completes it with a preset tidal volume or pressure gradient. But the deal that you need to know about assist control is that if when the patient starts the breath, the machine kicks in and completes it, so that the individual, the patient, doesn't have to do that work. So that in essence, you're conserving energy for the healing process. Now, synchronized intermittent mandatory ventilation, or SIMV, is when you're starting to, in essence, this is the setting you're going to wean the patient off the ventilator. And in essence, what happens here, it's almost opposite. The machine works opposite to what happens in, excuse me, in assist control. So with synchronized intermittent mechanical ventilation, basically the machine stops when a patient takes a breath. So if a patient takes a spontaneous breath, the machine will stop and let the patient take the breath. So with synchronized intermittent mechanical ventilation, the patient is able to get used to his or her own tidal volume. So that's you can that weaning process, taking the patient off the ventilator. So assist control is for your patient who is acutely ill with regards to respiratory status, and the lungs need to heal. They need to, in essence, let the machine do the work. So that's what assist control allows. SIMV is when you set the patient up so that he or she can get used to his or her own tidal volume. And you can, I'm sorry, go ahead.
Are you changing slides while you're
No, I'm going on that one slide, the modes of ventilation, you see?
Yeah.
And then I'll go into those other slides later.
Sounds
You
good.
have do you see where it says modes of ventilation? Is this the slide that you see?
Yes.
Yeah, okay. The slide that will follow, but I'm just going to give you an overview on this slide before I go into the other slides. All right, so assist control, the machine's doing the work. SIMV, the machine's starting to let the patient do the work. Now, pressure control ventilation is when there's really damaged lungs. So this is a setting that is primarily used in the ICU with people with really bad lung tissue. So it's a kinder and gentler means of ventilating the patient. So instead of pushing in a volume, it's pushing in a pressure so that the pressure doesn't go too high to damage already damaged lung tissue. Okay. And then the spontaneous modes are primarily what you see used, especially CPAP, when you're looking at things like sleep apnea accordingly, so that you can help keep the airway open, but the patient generates all the breaths. So with assist control, going over each one of these separately, you're setting a rate that's a backup rate, but once again, each breath is augmented by the ventilator. So the patient takes a little bit of effort and the machine completes it with either a preset tidal volume or a preset amount of pressure. What you need to remember is that assist control lets the patient, their lungs rest. It lets the machine do all the work. The machine is doing all the work for the patient in terms of ventilating. In terms of advantages, the slide tells you it provides full ventilatory support, and excuse me, and the patient is going to control the rate of breathing. So if the patient starts to become tachypneic, the machine's going to kick in at that fast rate, which is generally speaking also why patients are sedated accordingly. In terms of looking at assist control, you have to monitor blood gases, as with anything, to make sure that it's meeting the ventilatory demands and that you're not hyperventilating the patient. Is it okay? If Ian, please text me, okay? Because I have my cell phone right here. Okay. SIMV, this is when you're setting it up so that the patient is starting to now take his or her own breaths, and you're wanting to see how well they do with that. So what happens is that the machine, the valve on the machine closes when the patient takes a spontaneous breaths, so that you're placing machine breaths between the patient's own breaths. And therefore, you're allowing the patient to start to get used to utilizing his or her own tidal volume. Okay. It can improve patient comfort, but like I told you, you're going to, anybody acutely intubated on a ventilator is going to be sedated. And there's less of a chance of hyperventilation. But you need to also make sure that you're watching the work of breathing. You want to make sure that blood gases reflect the fact that this patient has adequate, oxygen delivery, and blood gases will show that accordingly. And once you look at blood gases, you're also going to intermittent, in between blood gases, you want to look at what their pulse oximetry is telling you. You have to be careful. One of the things in an ICU setting, for example, is that, we have a tendency to take a lot of blood. We're going to draw, lab values in the morning, lab values at night. We're drawing blood gases every 4 hours, every time we do event change. So the real deal is that you're looking at, you want to make sure that you're not taking too much blood. So that's why non-invasive monitoring is also important, to match up with what blood gas values are. Okay. And the idea is that you have a lot of resistance from the tubing. So I don't know how many of you have seen ventilated patients, but there's a long amount of tubing, and you need to consider that tubing as being problematic in terms of resistance. So now, besides looking at how you're delivering breast to the patient, you're looking through the mode. You also want to know, what is the machine actually delivering? So generally speaking, there's 2 ways that these modes operate. They operate by either volume or by pressure. Volume is when you deliver a set amount of tidal volume, irregardless of the pressure behind it. So if it takes normally when you're looking at a ventilator and you're looking at the dial and you're looking to see how much gas is going into the lungs, the pressure going behind how much gas is going into the lungs. Generally speaking, with lungs that are healthy, and you'd say, well, why would you intubate somebody who's healthy? Well, if they're on anesthesia or what have you. So somewhere between 30 and 35 centimeters of water is what you would expect. But sometimes when lungs get really stiff, if you start to hit 60, 70, that's starting to get to be stiff lungs. And you could do severe damage if that pressure gradient starts to go up, so that you may have to move to a more gentle means of ventilating the patient. So volume ventilation is you're going to deliver the volume, the tidal volume, irregardless of the pressure, which means the high pressure alarm limit on the ventilator is vitally important. So you need to know if that pressure is going up. Okay. Now with volume cycle ventilation, how you figure out how much tidal volume to give a patient is set on their body weight. So as you might remember, when we talked about spontaneous tidal volume, we said that it was 5 milliliters per kilogram of body weight. Okay. Now on the ventilator, you have all that tubing, which also sets up for some resistance. So how you calculate the tidal volume is higher. So it's about 7 milliliters per kilogram of body weight. So the ventilated tidal volume is calculated according to body weight, and that's 7 milliliters per kilogram of body weight. Okay. The volume in terms of delivery of that ventilation, I think the salient points to remember is it's going to be a higher number, 7 milliliters per kilogram of body weight. And you have to be very cognizant, not that you're not cognizant all the time about the high pressure alarm, but especially with volume cycle ventilation, you have to be cognizant of the high pressure alarm limit. Okay. And usually what they do is they set it about 10 to 20 centimeters above what the peak airway pressure is. Okay. So if your pressure gradient is 30, then they'll set it at 50. The respiratory therapist. Everybody okay so far with that? Okay.
Yes.
Okay. Now with pressure ventilation, this is when you have damaged lungs.
Professor,
And that may sound, I'm sorry? Yeah.
Professor, I read in the lecture that says that you say it's 7 milliliter per kilogram. I read in the lecture it could be 6 to 11. Would the lecture be
clinic? Yeah, but in terms of when you're looking at how it's clinically based. You know, when you go to the clinical area, they're doing 7 milliliters per kilogram. You don't see high tidal volumes. You know, it used to be 10 milliliters per kilogram of body weight, but they've cut back on that because of the fact of the damage that it can ultimately do in terms of volume. So, you know, the literature may say that, but when you're in the clinical area, it's generally speaking 7 milliliters per kilogram. I wouldn't mark you wrong if I put that as a question for you, but the reality is it's 7 milliliters. And when the ventilators nowadays, when you turn them on, the first question they ask you is how much does the patient weigh? And the machine themselves will actually calculate what the tidal volume should be, based on at least the 840 is based on 7 milliliters per kilogram. So that ventilator picture that you're seeing, that's the Puritan Bennett 840, and that's a very common ventilator that's used. It has actually the largest share of product on the market in the United States. So, but that's a good question. But you know, but the deal is that most commonly it's going to be 7 millimeters of you know, for tidal volume.
Sounds good, Professor.
Yeah, and then somebody's asking me, are patients, well, I guess by measured daily, are they weighed daily? Well, patients in an ICU setting or that are this acutely ill should be weighed daily. You know, not just about the ventilator, but also to tell you about fluid volume. Okay, your intake and output tells you how much, how you got to a certain point, but you need the daily weights to show you what that point is. So let's say somebody lost 2 liters of fluid, you look to your intake and output and see that they put out a lot of urine, or was it that they vomited, or was it that they had profound loose diarrhea? So that would be the deal. So are they measured? Are they weighed daily because of the ventilator? Not directly, but it does impact how the ventilator is used. They will look to that. Pressure ventilation is when somebody's got really damaged lungs. So sadly, these people with COVID-19 have very bad damaged lung tissue. So if you're going to push in a volume, irregardless of the pressure, that can be problematic to that lung tissue. So pressure ventilation, more gentler means of ventilating the patient. But the alarm that becomes very important to watch on this is going to be the return tidal volume. It's going to be very important to watch on this, the return tidal volume. Because if you're just going to put in a set amount of pressure and your lungs are very stiff, you're trying to be gentle in terms of ventilating, but you may not get in the volume that you need. And the other thing that's going to be monitored on the patient is if your tidal volume is going to be compromised, then you're not blowing off CO2. So the other thing that you're going to see continuously monitored is going to be end tidal CO2. All right. So pressure ventilation is used for damaged lung fields because of, generally speaking, excuse me, interstitial lung disease, and you need to be very cognizant of the return tidal volume to make sure that this is truly benefiting the patient. And concurrently, you're most commonly going to be monitoring end tidal CO2 to see that they are blowing off the carbon dioxide. Now this slide is just basically reinforcing what I just said. But this is where when you're very to a ventilator, they're not only going to need to be sedated, they may need to also, in a later time, concurrently be paralyzed. And, you can say paralyzed. Well, yeah, they're going to use Pavulon or derivatives, like, accordingly. And they're going to paralyze the patient so that their lungs will subsequently not, work with the, further be able to work with the machine. So in terms of looking at, patients on pressure control ventilation, you're going to see that they'll be sedated, but they will be also paralyzed as well. So Nimbex is a more commonly used paralytic agent. Now, when somebody's sedated, that's when you're going to use the Richmond Agitation Sedation Scale. So that's the RASS. And if you look in the Blackboard and you see where I put clinical resources, and there's an SBAR form there. If you look on the back of that, or page 2, you'll see I put the RASS scale there. And what's good about the RASS scale is that it not only assesses sedation, it does also assess agitation. And with regards to agitation, in the old Ramsey scale, it just said, are you agitated or you're not agitated? But in this scale, it shows different levels of agitation accordingly. So, the RASS scale is what is used to assess agitation. Sedation as well. So the Richmond Agitation Sedation Scale is used to see how effective the sedation is. And your primary care provider will tell you at what level they want to see it at. Now, as far as, when you're paralyzing somebody, what you're going to utilize to see how significantly the person is paralyzed is the peripheral nerve stimulator. And that's something that is, in the OR, they use it all the time because, they paralyze you, they sedate you first, or else you're going to hear, see, and feel everything. And then they paralyze you. And the point of paralyzing you is so that you don't move so that the surgeon can do his or her job. Okay. So with the paralyzing agent, they use the peripheral nerve stimulator, which is basically, generally speaking, you see, wait a second here. Anybody acute, somebody's asking me, do just these patients on pressure control ventilation need to be sedated? Any patient who's acutely placed on a ventilator needs to be sedated. So, all levels. But if the key here is that they're acutely placed on a ventilator, so they need to be sedated. It's with pressure control ventilation, this is the patient who is extremely critically ill. And you're seeing that critically ill state because of the severe damage that the lung fields have experienced. So, that's the movement in that direction. I'll put on Blackboard a picture of what, how you test for the peripheral nerve stimulation, and subsequently what the response should be, that you're not totally paralyzed, but that you have a mid-level range of paralysis. So you have 2 twitches where you'll hear the clinician speak instead of 4 twitches. Okay. Now, the other thing that you might see with the pressure control ventilation, what did we talk about earlier? We said that the I/V ratio is normally what? 1:2. Okay. Now, what can also be done now that the patient's paralyzed is that you can increase that inspiratory phase so that you're getting the gas into the lungs, but you're doing it over a longer period of time at a set amount of pressure so that the lungs are not, are not further damaged accordingly. So the problem is that if you increase the inspiratory time, you're going to decrease the expiratory time, and you have a problem, once again, potentially, not necessarily, but potentially with CO2 retention, which is why you need to have that end tidal CO2 monitor. Okay. Now, basically, as I mentioned earlier, you need to make sure that the patient is paralyzed and sedated. You also need to know that you can deliver pressure control ventilations by either of the two modes, all right, which is assist control or SIMV, all right? So there's two types of ventilation, just to regroup. Volume, you're delivering tidal volume regardless of the pressure. The high pressure alarm is really important at this point. And then you have pressure ventilation, which you're looking at what's the return tidal volume, and you're monitoring the end tidal CO2 because you want to make sure you don't cause CO2 retention. And going back a step further, anybody acutely intubated on a ventilator needs to be sedated. Okay? That sedation, the addition of paralyzing a patient happens when the patient becomes more acutely ill from a respiratory component, and subsequently you need to paralyze basically their lung fields as well, general paralysis, in order to facilitate good lung expansion and treatment for that patient. Now, the issue in terms of pressure control ventilation, it limits barotrauma, which is the damage to the lung fields. It can recruit alveoli, and it can improve gas distribution so that the ventilation perfusion ratio is okay. Once again, the idea of tidal volumes may vary because of compliance issues. And we'll talk about ARDS, acute respiratory distress syndrome, and in some instances, pulmonary edema. But the idea is that the end tidal CO2 monitoring, as well as the return tidal volume, is what's going to help you monitor that. So that, once again, in terms of indications for pressure control ventilation, you want to make sure that, that basically you're able to recruit alveoli, and pressure control ventilation usually also incorporates that adjustment of the I/E ratio. Now, pressure support ventilation is also a tool that is used for weaning, but it's also a tool that's used so that, again, you're not further damaging lung tissue. And with pressure support ventilation, what the machine is doing, it picks up the patient is taking a breath, and it assists the breath with a preset dialed in assistive pressure gradient. So patient takes their breath, but receives added support through pressure from the ventilator. If that pressure, why you're using pressure support ventilation is to overcome airway resistance and to help augment your spontaneous tidal volume. Now, there's two types of way pressure support ventilation is utilized. The low pressure support ventilation under 10 centimeters of water pressure is used for helping you to start to wean the patient off the ventilator. If you're using more than 10 centimeters of water pressure, remember, pressure gradients for the ventilator is always measured in centimeters of water, okay? So if it goes above 10 centimeters of water, then you're actually doing a form of pressure cycle, complete pressure ventilation. But it's supporting the pre-existing breaths that are there. The advantages of pressure support ventilation is that the patient is doing all the breaths. All right. So you need to, so that the patient is controlling their breaths. It provides better patient comfort, and it helps to overcome the work of breathing. The disadvantages are that it may not support the patient enough. So obviously you have to look at return tidal volume, and you have to look at what the patient looks like. It's like sometimes we get hooked into too often to look at numbers and to look at machines, as opposed to looking at the bigger picture. So if your patient looks fatigued and looks like they're tiring, then it's no good, and it's no benefit to the patient. So so you have to look at the bigger picture. You have to look at how does the patient look to you, as opposed to just what the numbers and the machine is telling you. And before, in terms of pressure support ventilation assessment, you're looking at expired tidal volume, and you're also looking at the respiratory rate. And people that are candidates for pressure support ventilation are those who have an intact respiratory center. Now, all those settings that we just talked about deal with ventilation. These two settings that we're going to talk about, and actually there's a third setting, deals with oxygenation or oxygen delivery. Now, when you're looking at, just backtracking a little bit, when you're looking at your respiratory system, your respiratory system brings oxygen to the cell in two ways: ventilation, and it assists also in oxygenation. So the ventilation part is what we just talked about, but now we got to deal with how you're going to deal with the oxygenation part. Now, oxygenation, you obviously, what you're forced in, your fraction of inspired oxygen is going to help supplemental oxygen, which the machine will tell you. So your FiO2. Now, PEEP and CPAP will also help, because they keep let me just go back, because they keep the alveolus distended. And by keeping the alveolus distended, that diffusion pathway less, so there's more ability for oxygen to diffuse across that diffusion pathway into the vascular bed. Now, PEEP. What is PEEP? All right. PEEP, as you see underneath on the bullet there, is positive end expiratory pressure. So on ventilated breaths, a certain amount of pressure exists at the end of the ventilation. So the indicator never goes down to zero. The pressure gradient will never go down to zero when you have PEEP. Generally, PEEP is set at 5 +5 to +15. With a normal ventilated breath, you're going to see the indicator go down to 0, but on a breath or a ventilation, rather, that's provided by the machine, the indicator will only go down to what you have PEEP set at. So if you have PEEP set at 5, it's going to go down to 5. If you have PEEP set at 10, it's only go down to 10. All right. And CPAP is used for spontaneous breaths. So PEEP is for ventilated breaths. CPAP is for spontaneous breaths. Now, PEEP increases your functional residual capacity, so therefore it improves oxygenation. So what does that mean? That means that you're keeping the alveolus distended so that there's less of a diffusion pathway, so more gas can go into the vasculature accordingly. CPAP is continuous positive airway. There's no mechanical assistance, and it just provides positive pressure when you're breathing, so that it keeps the airway open, so it doesn't collapse. And you've probably heard of, I hope maybe, CPAP masks that are used for people with sleep apnea. CPAP can decrease the work of breathing. It can provide tidal volume, and its tidal volume and rate is determined by the patient. And if CPAP is provided on the ventilator, it's going to be utilized to help extubate the patient. Okay. So, whenever you have, I've talked about alarms. And one thing I want to say about alarms, no matter where your alarms are, you want to make them specific to your patient. Okay. You don't want, you don't want to just have the default alarms and then alarms just being white noise. And what do I mean by white noise? Well, the combination of all colors is white. Okay. So that means that things are blurred together. So if it becomes white noise, you're not going to hear them anymore. So you always want your alarms to be specific to the patient. You always want your alarms to be specific to the patient. So you're going to see these alarms set on the ventilator: high pressure, low pressure, airway pressures, high respiratory rate, low respiratory rate. You're going to be looking at volumes. You're going to be looking at tidal volumes as well as minute volumes. And then the machine is also going to pick up, is the patient apneic? Because patients can become apneic on the ventilator. You may be weaning them, or maybe you have them on pressure support ventilation, and all of a sudden their respiratory center stops functioning. They can become apneic. So those alarms are usually set somewhere around 15 to 20 seconds. So the patient stops breathing between 15 and 20 seconds. Then, then the machine will kick in with a backup oxygen, FiO2, tidal volume, and respiratory rate. Now, these are the 3 most common alarms that you might see. All right. The first one would be your high pressure alarm limit going off. And as I mentioned earlier, it's usually set 10 to 20 above the peak airway pressure. So PIP is peak inspiratory pressure. And primarily, what you have to worry about with a high pressure alarm limit is the fact that there's some kind of resistance in the airway. And generally speaking, it could be lung compliance. It could be some type of resistance in the tubing. From secretions, the patient may need to be suctioned. The patient may have water in the tubing. Remember that water never gets poured back into the system. It always gets poured off, okay? And then, oh, sorry. And then when you're looking at low pressure alarm limit usually means disconnection. And disconnection doesn't mean that the patient's disconnected from the ventilator circuit, the tubing on the ventilator. Generally, it could be that, but also be that pulls, one of the little parts that is in the tubing may be open. So you just have to look for the integrity of the system. If ever you're uncertain about that, you just, you ambu bag the patient, take them off the ventilator, ambu them, and then have a colleague, unless you're ambidextrous, look at the tubing to see, is everything intact? And if nobody can figure it out, you get respiratory. I already talked to you about, okay, low exhale volume can also lend itself to that as well. Low exhale volume can lend itself to that as well. You're also going to see the high respiratory rate. And you're looking at an apnea, and I went over those. Okay, now what are some of the complications of being on a ventilator? What are some of those complications? Well, one complication could be it's a piece of equipment. The machine can fail, all right? So that you need to make sure that you have an ambu bag there, as well as a face mask, as we talked about with regards to endotracheal tube and tracheostomy tube. And obviously an oxygen source. And all ambu bags, I'm not sure what they're doing now, but all before COVID-19, all ambu bags are single use only, meaning that not single patient only. I shouldn't say single use, single patient only. So once the patient gets extubated, you throw out the ambu bag, accordingly. You don't save it. It's not going to get sterilized. It gets thrown out. With regards to cardiovascular compromise, if when you're suctioning a patient, if they're not chronic in nature, they may throw some arrhythmias. They may start to have a change in vital signs. In terms of barotrauma, because it's positive pressure going into the lungs, that's not normal physiology. If you start to go up on those settings, CPAP and PEEP, for example, not so much CPAP but PEEP, you could rupture an alveolus, so you could cause barotrauma. So that's why it's important to monitor the peak inspiratory pressure. Now, another thing, as with any piece of medical equipment, you're looking at ventilator-acquired pneumonia. All right, so anything that is placed inside the patient, you always have to assess, do they still need it? Because once you go past the normal protective components of the nonspecific framework of your immune system, meaning your skin, meaning going, into the vasculature, all right? You're setting the patient up for an infection. And in the case of the ventilator and you're intubated, you're going into somebody's lungs. So as you might know, there's two types of ways things are looked at in terms of infections. Community-acquired infections, CAI, you'll see, they tell you, Joint Commission tells you never use abbreviations, and it seems to me that that's all we use all over the place. But anyways, so community-acquired infection, CAI, which means that the hospital is not responsible for that, okay? So that, and why does that matter? Because it has to do with Medicare, Medicaid reimbursement. And if it's community acquired, you're going to get the full reimbursement. Whereas if it's hospital acquired infections, HAI, also sometimes known as nosocomial, that means that you caught, not you, but the hospital caused the infection, and therefore there's some restrictions on reimbursement. So that you want to see, does that person need that medical device? And you're going to assess that on a daily basis. So it's not just going to be a ventilator, it would be a central line, it would be a Foley, okay? So that in terms of preventing ventilator-acquired infection, you want to elevate the head of the bed, you want to put the patient on what they call sedation vacation. So remember what I said, every acutely ill, anybody who's acutely placed on a ventilator needs to be sedated. So that you're going to let that sedation up, meaning you stop it, and then you're going to look to see what the patient's pulmonary functions are to see if that individual can get extubated. You also want to make sure that you have peptic ulcer disease prophylaxis, obviously to prevent it, and because gastric secretions that are sitting around there can cause gastric upset and can cause damage to that mucosa as well. You also want, please come back. You also want to prevent deep vein thrombosis. And, we really don't use those stockings anymore because those stockings don't do chops and TED stockings. You may not, you're not, hopefully you're never going to see them. You don't hear from them because they provide pressure in terms of some return in terms of circulation, but they're not mimicking normal physiology, right? So you may have seen, I'm not sure, but you may have seen what they call sequential, devices, in terms of pressure. And you'll see some kind of like sleeve placed around the calf of somebody's leg. And what those sleeves do is they mimic the normal muscle contraction in the leg when you walk. So, because you're not constantly having pressure. What you're hold on. You're not, sorry about that. You're not looking at the pressure. You're not having constant pressure, so you have to relieve it, and then you have in terms of it's an on and off kind of deal. So that sequential pressure is what mimics normal walking and is a better indicator of good circulation. Those stockings, yeah, they do provide some return, but they can also, if they're not appropriately measured, can also actually do the opposite. Now, the other thing you have to worry about to prevent in terms of ventilator-acquired pneumonia and management of the patient on a ventilator is oral care. And this is a big one because people think, oh, you got an ET tube. They forget about the mouth, and they forget about the nose, okay? So the idea of every 4 hours making sure you suction out the mouth and packets that are available to help you do that, so that you're cleaning out the mouth, you're getting rid of good you're doing a strong job in terms of the chlorhexidine is doing a strong job in terms of killing off that bacteria. You're just suctioning it out, so that this way the person also may not aspirate that as well. Okay, so oral care is vitally important. Now, this is a sedation vacation. I'm not going to ask you to know this, but you know, it's just something for you to be aware of, that this is what they do in the hospital setting. Now, what are some of the further complications with regards to mechanical ventilations? Well, it's psychological. You know, the person is going to know they're sick. I mean, that sounds redundant. It's obvious that they're sick, but they'll know how acutely ill they are. And, so that's why sedation is also important, as well as,
Professor, I didn't-
you know,
you didn't-
providing. I'm sorry?
Professor, can you repeat that? We didn't hear anything you said there. You broke up.
It's just that when somebody's intubated, they, you know, the individual knows if they have awareness, mental status, they're going to know that their condition is severely worsened. So that, you know, the sedation that you're going to give them anyway will help with that, but you still need to be there to support them accordingly.
Thank you.
Yeah, no problem. And then another complication of being on the ventilator is something that we'll also talk about with the endocrine system. But it's important to take note here, and that anybody on a ventilator gains about 1 kilo or 2 pounds worth of water. Now, what is that? Why is that? Okay. You have all that positive pressure in the thoracic cavity. Okay. And all that pressure in the thoracic cavity is pressing down on the heart and your venous return. And the heart, you know, I'm not saying it's totally shutting down the heart, but it's decreasing the volume of heart steam. So subsequent to that, I says, gee, I don't have enough fluid. So what it does is it then releases a hormone, ADH, antidiuretic hormone, that then holds on to fluid in the body. But the reality is you do have enough fluid. It's just that the baroreceptors, or those receptors in the heart, is saying, I don't have enough fluid. So it's releasing a hormone that's saying, I'm going to hold on to fluid. So what I just described to you is something known as SIADH, Syndrome of Inappropriate ADH. And generally speaking, it's usually not a major complication that you see with ventilated patients, but it is something that you need to consider. Okay?
Professor, is that
Now,
1 to 2 pounds per day or just 1 to 2 pounds flat?
flat. It's not good. You're not going to build it up. It's generally speaking, you know, in terms of just the whole incidence of the intubation and ventilatory process on average. Some people it may be more because they have you know, disease entities that might cause it to be more. But somebody asked, would you put these patients on diuretics? It would depend upon what their total fluid balance is. But that's a good question. And that is something that is generally considered. So if you have somebody with heart disease and they're further adding fluid retention, then yes, you would consider diuretics. Okay. Anybody intubated for more than, you know, a surgical intervention, you know, the operative period of time, should have an NG tube, because even though you have the ET tube in place, it's a cuff at the end of it, and it's making it a closed system. It's never completely closed, so that, you know, you could push a little bit of air into the stomach. So an NG tube to decrease the potential of gastric distension is something to also consider. This is the slide you should take home. All right. And, you know, not just, you know, for this course, but in general. I also put a brochure that I had put together at Bellevue to help people understand, assessment. They could keep it in their pockets to augment the classes that we gave back there. So, and it basically has this on there already. So if you look on Blackboard, you'll see that. And I think I put it in the workbook. Excuse me. So in terms of ventilator assessment, what you need to remember is with every single patient, with every single piece of equipment, you always start from the patient. There's always these cartoons that show you everybody's like running around, they're managing all these pieces of equipment, and there's the patient standing in the corner, So it's the idea is that, obviously an exaggeration, but the idea is that you always start the patient. And also you need to know that patient, you have to know the patient's anatomy. So if a person, I think I mentioned this earlier, if a person has 2 lungs, that's, then they have 2 lungs. But if they have a pneumonectomy, you have to know, you have to take consideration of the fact you're not going to hear bowel sounds. You're not going to hear breath sounds from that side. So you have to know your patient's anatomy, okay? And lots of times when I stress something, it's not because, I've been thinking of this, it's because I saw it. I remember this one gentleman came in, he had TB, and we hooked him up to the vent, and the vent kept alarming. And when we looked, I saw a scar on one side of his chest, and I said, "Did this man have a pneumonectomy?" And then the physician said, "Oh yeah, that's right." And that's when we cut his tidal volume down. And obviously, we didn't hear breath sounds strong, because you can hear something referred from the other side, but it certainly is not a strong sound. So, so you really need to know your patient's anatomy. And that was many years ago. And anyway, I'll just leave that alone. Okay, so in terms of the first thing you're going to do is you're going to listen for breath sounds. You're going to see that there's air exchange in both lungs. And then you'll obviously listen further to see if there's adventitious breath sounds accordingly. And I forgot to put an online breath sound for you to refer to, but I will do that later on. So you're going to listen for breath sounds. Then you're going to identify the airway. And what do I mean by that? Is it an endotracheal tube or a tracheostomy tube? And then you're going to put down the size. And you're also, with the endotracheal tube, going to say at what point is the tube in the mouth. So, it's going to tell you how far down the tube is. And now with endotracheal tubes, which I'm guessing that, I don't know, they probably are running out of those too, is they tell you not to use adhesive tape. They're telling you to use a commercial holder, endotracheal tube holder. And if you looked at the video, the New England Journal of Medicine video about intubation, I think they show you on there an example of a commercial holder, because those things are more stable than you using adhesive tape, okay? Cuff, you're going to measure the cuff pressure. Well, you'll find out who does that. Is it respiratory or is it you as the nurse? But the cuff pressure should be no more than 18 to 20 millimeters of mercury. It's different with the cuff pressure. That's the only thing you're going to use millimeters of mercury for with regards to the respiratory system, because the 18 to 20 is below that 30 millimeters of mercury where capillary flow is at. So you never want to go above 30, because what will happen there? What will happen is you'll cut off circulation, no circulation, death of tissue. So I think I mentioned to you that if that happens and the trachea gets eroded posteriorly, you're eroding into the esophagus. If you erode anteriorly, you're eroding into the innominate artery. All right, it's not, and the posterior erosion is no good. Nothing like that is accurate, but there is a potential for that to be corrected. But if you erode into the innominate artery, morbidity mortality rate is extremely high. So you never want that to happen. So the adapter that you see coming off of the endotracheal tube, as well as the tracheostomy tube, that also gives you a sense of what it feels like inside the trachea. So if that's really tight, then you know that you should be measuring that and making sure that it's not compromising the tissue in the trachea.
Professor,
Then you're going to put. Go ahead.
just out of curiosity, if you happen to find that the cuff pressure is like between 21 to like 29, do you tell the respiratory tech, or do you actually deflate it yourself?
It depends on what the policy is in your particular facility. All right. In Bellevue, you would just adjust it, and then you would make sure that there's no air leak, but you would just make sure that the measurement of the cuff pressure is about 20. Yeah, the nurse would fix it as long as you've been trained to do so. I mean, that's there's a device that you can do, or you could use a manometer. You could use you could use a blood pressure cuff, the aneroid part, take off the cuff, and then put a stopcock and a syringe, and you could measure it. But that's something that you would have to be a skill you'd have to be introduced to and to be shown. But I do know, like I said, at Bellevue, we train people to do that, or at least while I was there, we trained them to do that. Now, but respiratory therapy also should be following that as well. Okay, the next thing that you're going to look at is what type of ventilator is it, and what do I mean by that? Well, there's all different companies out there, but like, for example, at Bellevue, the Puritan Bennett 840 was the machine used. But there's other machine that they use, the iVent. And the reason they use this machine called the iVent is because it's also MRI compatible. So you're going to use it for patients who are, have to go into the MRI, but also it's also a much smaller machine than the Puritan Bennett 840. Doesn't do as much. So like for somebody who is really critically ill, in terms of respiratory status, this is not going to be your ventilator of choice. It's just that it's smaller. It's smaller than other machines, so it takes up less space. So like in Bellevue, they use it in the recovery room sometimes for that reason. So you're going to say the name of the ventilator that you're using, because and also it's important in terms of if there's problems with the device, you need to go back on it, needs to be reported to the FDA. Just doesn't deal with drugs. The FDA also deals with equipment, and you need to be clear if something failed on a piece of equipment to let them know so that they can keep track of it. All right. In terms of the next thing would be the type of ventilation. So is it pressure or is it volume? Then you're going to talk about the mode. Is it SIMV? Is it assist control? And then you're going to talk about what's the set rate. All right. So what's the machine setting it at the rate? And then you're going to assess what the total rate is. So what the machine and the patient are doing. And with volume cycle ventilation, you're looking at monitoring what the set tidal volume is. With the pressure cycle ventilation, you're looking at the peak inspiratory pressure. Then you're going to assess what's the return tidal volume, what's your peak airway pressure, and to make sure that that pressure alarm is set appropriately. You're going to look to the FiO2, And then if patient's on PEEP or CPAP, remember, it'll actually say it on the top bar, and I'll show you. I think I have a picture. I'll show you on the next slide. And then if they're on pressure support. And then you're going to look to what's the IDV ratio, the peak flow, and the delivery curve.
Excuse me, Professor.
Go ahead.
You said something about PEEP and CPAP. You said CPAP was used for what again?
Spontaneous breaths,
And then PEEP was used for?
ventilated breaths, so machine
right.
breaths.
Thank
Right.
you.
Yeah. Now, once again, in terms of ventilator alarms, these are the 3 most common ventilator alarms that you can see. High volume is going to tell you the patient. Most commonly, it's going to tell you the patient needs to be suctioned. There could be water in the tubing, but remember, that gets poured off. And maybe the tube slipped into the right main stem bronchus. So it's not aerating both lungs. It's just aerating one lung. High pressure by itself could be that your lungs are getting stiff. Low pressure would mean a disconnection or a leak on the cuff. Now, as I mentioned before about end-tidal CO2, you're looking at monitoring that. It's becoming more of a protocol on all ventilated patients, but I'm guessing, I'm not sure that I'm thinking about what's going on now, and that's another device that may be in short availability. But anyway, so end-tidal CO2 is something that you would generally see utilized for monitoring the ventilated patient. And these as I mentioned earlier, these CO2 detectors are utilized for intubation more. That you're looking at a color change, as you see in the diagram, to show you that the tube is actually in place, that you see gas exchange. And that's a further picture of a description. Nellcor is the most commonly used device. It is not the only device, but all of these devices, no matter who produces it, will change color to the like I said before with weeding, the goal is you want to get this person extubated, because any medical device in a patient that goes past your normal flora of protection is a source of potential infection. So with regards to looking at that weaning criteria, you're going to look to, first of all, bringing down the FiO2 to its lowest point that's acceptable. In terms of, 21% is room air, but if you bring it down to 40%, that's okay, because that's doable in terms of supplementation. And remember about oxygen toxicity. So you want to get rid of what's going to cause the most damage first. Then you're going to bring down the PEEP. And you're going to bring it down to the point that it's at least 5 or below. And you'll hear them talk about physiologic PEEP. So like 5 or below is what they call physiologic, and it has to do with the tubing. So in regards to, you want to bring down the PEEP, because it actually augments the complications of the ventilator, as I mentioned earlier, that idea of SIADH, the idea of the barotrauma accordingly. You want to bring down the SIMV to 4, because you want to know that the person can adequately breathe on their own. And then you want to make sure that that pressure support is less than 10. You also want to make sure that the person has like I mentioned before, it's one thing to look at numbers, but you got to look at the patient. So are they in a good nutritional status? Are their electrolytes within normal limits? And one of the big ones that actually the 3 that I listed there the three that actually impact muscle control most directly. And you might remember this. You know, magnesium, right? If your magnesium and your calcium are low, you know, you're going to have some tetany, some muscle stiffness accordingly. So that you want to make sure that those two numbers are okay. Phosphate, if your phosphate level is low, it presents as if it's very similar to Guillain-Barré. So you have an ascending muscle weakness. So you want to keep that phosphate within a certain range in order to facilitate good muscle control. So it's not Guillain-Barré, which is ascending muscle weakness seen after a flu, which is another thing. I wonder how many of these COVID-19 patients are going to present with Guillain-Barré, because when you read the literature on the Spanish flu, it's when they recognized, you know, they recognized Guillain-Barré. Anyway, well, I digress. But anyway, so phosphate is you know, if your phosphate level is low, you could present with that. So you want to keep that phosphate level normal. Now, these three electrolytes are the three electrolytes that are not like when we give Lasix and then somebody diureses and they lose a lot of potassium, okay? So it's not like a knee-jerk reaction. This happens over time, a couple of days. So then the question, you know, the real deal is that causing it, meaning the hospitalization, you know, because we're not necessarily, you know, feeding the patient adequately, and the importance of nutrition is vitally necessary in terms of making sure that all of this is made available. Phosphate, if you eat anything that came out of the ground, you're going to have phosphate. So even if you eat junk like potato chips, whatever, it's going to have phosphate in it. So there you go. So you brought the settings down, the person's in a good nutritional status, and now their pulmonary function tests present, you know, the respiratory therapist will stop by and do the pulmonary function test to make sure the person has a good spontaneous tidal volume. And the key here is spontaneous, right? So that's 5 milliliters per kilogram. A good respiratory rate. So they're breathing 16 to 20. You know, if somebody's got a respiratory rate of 28, this is not good. They're not going to stay extubated, all right, or 30. Negative inspiratory pressure. Remember, you need at least negative 25 in order to be extubated. And then your vital capacity is at minimum 2 to 3 times your normal spontaneous tidal volume. And then the person, if that's all in place, then the person is ready to be extubated. All right. Now, the process of extubation is not one where you just pull out the tube. All right. And generally speaking, nursing is not going to extubate the patient. Maybe respiratory therapy in your particular agency that you're working at, but it could be a nurse. I shouldn't say it's not nursing, but it could be a nurse who is credentialed to extubate the patient. So I'm not going to hold you to remember this, but I'm just going to introduce it to you so that if you see it, it'll be something that you may remember was discussed with you. But when somebody's getting when they're taking out the endotracheal tube, basically you need 2 suction catheters. All right. So what you're going to do is you're going to suction down the endotracheal tube to clean it out, in essence. So you're suctioning on withdrawal. You're then going to suction out the nose. Okay. And then you're going to suction out the mouth, because that's in terms of the colonization process. So your endotracheal tube is theoretically sterile. Your nose has much more colonization than, you know, obviously your endotracheal tube. And then your mouth has the most colonization. So you're going to suction all of that. the other reason, especially is suctioning out the mouth, is when that cuff gets deflated, when you're going to finally pull out the tube, whatever is sitting on top of it from ultimately dripping from the pharyngeal region could actually be aspirated by the patient. So you're going to go down the endotracheal, down the nares, clean it, suction out the back of the mouth, throw out that suction catheter. Then you're going to get another sterile catheter, and you've got sterile gloves on, and you're going to put the suction catheter down the tube. Then you're going to deflate the cuff and suction as you pull out the endotracheal tube. So the patient gets one more good blast suction, and any kind of aspirate that might be on top of the cuff or from the back of the throat gets suctioned out as you're pulling out the tube. So it's not just pull out the tube, okay? All right, now, in terms of the nursing process with regards to the patient, ventilator, you're looking at neurostat. Hello? No. In terms of, always remember that the brain needs two things, and it needs it in the exact form as I'm saying it. You need oxygen because it can only deal with aerobic respiration, and it needs glucose because it can't deal with utilizing fat or protein as an energy resource. It has to have clear glucose, so it needs oxygen and glucose in order to support itself. So neurostatus is important. All right. And then you're going to look at the settings on the equipment. Now, the top part here, can you see where I'm pointing to? Can you see where I'm pointing to?
Yes.
Yeah. So on the top, you're seeing, how the patient is responding to the machine. On the top, you're seeing how the patient is responding to the machine. Down here are the settings, okay? And over here is your alarm system. And most alarm systems kind of work in the same way. Green means everything's fine. Yellow means an alarm was violated. And red means a life-threatening alarm was violated. And what I didn't point out to you is that your circuit has two pieces of tubing. One is the inspiratory side and one is the expiratory side. And when you're looking at that, the inspiratory side is where the humidification has to be placed and where you're going to see a temperature probe placed so that you know that you're warming and you're moistening the airway, right? So it's the inspiratory side that you're going to see the humidification. It's also usually the inspiratory side where you're going to see the inhaler or the nebulizer treatment given. And in rare instances, you could see a nebulizer treatment being given on the expiratory side. And actually, I think I heard somebody talking about that, one of my colleagues. Anyway, she was asking me questions about that. So I'm not in terms of with the COVID-19. So that in planning, you want to make sure that your patient has a patent airway. They have good gas exchange. They don't have infection or trauma. They have optimum mobility depending upon the situation they're in, meaning, you're turning and positioning them. That you're giving them a means of communication and that you have good coping measures for the patient. One of the things that if somebody's intubated for a while because they have a chronic condition, like with COPD, they need to have a focus of control of their environment. So that as a nurse, you have to work that. You that be it should be. But in the long run, there's situations that you may have to give directions for the safety of the patient that they may not necessarily be in compliance. But the idea is that you, as much as possible, you want the patient to feel that they're in control of you and that they have control of their environment. So that communication board and following what that individual wants or needs in terms of placement of even their own bedside accoutrements is necessary. That, in terms of nursing diagnosis, impaired gas exchange, ineffective airway treatment, risk for trauma, impaired physical mobility, impaired verbal communication, defensive coping, and the sense of powerlessness. So that you enhance exchange, promote effective gas exchange, prevent trauma and infection, promote optimal level of mobility, promote good communication, promote coping ability. And you want, in terms of, sedation, anybody acutely ill needs to be sedated, acutely intubated needs to be sedated. You're obviously looking at repositioning. One of the things that they're doing, because this COVID-19 is interstitial, is they're also doing prone positioning. And that prone positioning, they're not using those fancy beds. They're just, they're using, basically simple, old time, putting them on their stomach and proning them accordingly. You also want to assess fluid balance and administer whatever the medications are to control the primary disease. Is it pneumonia? Antibiotics. Going to listen to lung sounds for effective airway clearance. Suction the patient, chest pulmonary toilet, humidification of air, and airway medications. Those are the nebulizer treatments like albuterol or Alupen. Not Alupen, albuterol. In terms of trauma and infection, we talked about infection control measures, the idea of tube care, oral care in particular, cuff management, and keeping the head of the bed up. Now, the rest of this stuff kind of lends itself to immobility in general, the idea of range of motion, the idea of communication, the idea of stress, and family, the idea of caregivers accordingly. Complications, we talked about decreased venous return, so that would be decreased cardiac output. You're going to monitor vital signs accordingly. You're going to look to barrel trauma and pneumothorax, as we talked about, because of the positive airway pressure. And then you're going to assess infection, assess the need for the machine for the potential of infection. And then, because the person is sedated in the ICU, most commonly, or in some type of step-down framework, you have to also assess delirium. I'm going to put it under the clinical assessment tools, but I will put, so the two things I owe you with breath sounds and this, because delirium in itself will add to the morbidity, mortality of an acutely ill individual. Generally speaking, in an ICU, but not necessarily. And delirium is actually something that's a reimbursable diagnosis. So with delirium, you want to make sure that you prevent it, because it'll just add to bad outcome. You know, in terms of looking at the ventilator, the primary indication for mechanical ventilation is existing respiratory failure. And there are many settings that can help you to support an individual patient. And obviously, a successful ventilator management involves understanding and maximizing the benefits of the ventilator. This is true for anything that you do. You want to maximize the benefits to minimize the risk. So it's not just being on a ventilator, it's just in general. You want to maximize how you would prevent delirium is by making sure that you're sedating the patient appropriately, and that you would make sure that that the patient is appropriately resting. So in terms of controlling their environment, meaning that, you know, I remember years ago, actually not that long ago, now that I think about it, but I was taking care of this gentleman who was a FEMPOP bypass. And I went in every, you don't know, but I went in every hour, did his Dopplers, checked his vital signs, checked his urine output, asked him if he needed pain medication, was he okay, whatever. And he seemed to me that he was resting fairly comfortably. And he wasn't nasty to me or anything. He says, at me, and he proceeded to tell him exactly what I did every hour. So the physician says, well, that's what she was supposed to do. And he walked out. But it became apparent to me that, you know, what you think may be not affecting the patient is actually disturbing the patient. Now, this guy was in his 50s, but if that was an 80-year-old, somebody in their 70s, late 70s, that might have had a different effect on that individual. So in summary, what you need to do is just to make sure that you kind of like manage your activities in a way and remind the patient that your activities are such that, you know, may interfere with some of what they perceive as their rest accordingly. So it would be to, to coordinate everything together. Okay. Coordinate nursing activities together. And that would be it. All right. So I'm going to let you guys take a 5 everyone.
Professor, you're breaking up.
can
We can't hear anything you're saying.
I'll give you guys a 5-minute break, so that, you know, and then we'll come back and finish this all up, okay?
Okay.
All right. So 5 minutes. All right.
Thank you, Professor.
Okay. But just 5 minutes.
Sure.
Okay.
I'm here.
Ready.
And I am going to send out test drives. It's just, I mean, not that you need to hear this. I have an older friend who just had cervical laminectomy 2 weeks ago, and she's not doing well, but she's at home. So I've been kind of going to her house. So I've missed the post office. So I will mail it out. I will mail them out on Monday. Hopefully. Okay. The flow drives. Yeah. All right. So anyway, thoracic surgery. All right. Why would you have thoracic surgery? And that's to basically relieve conditions like lung abscesses, lung cancer, cysts, different types of tumor, and when there's issues with regards to non-functioning alveoli in emphysema. Preoperatively, what you're going to do is you're obviously going to see that there's a diagnosis, and you're going to make sure that the airway is maintained. You're going to educate the patient, and you're going to relieve any anxiety. Postoperatively, you're going to primarily check, generally speaking, postoperatively, you're going to have continuous monitoring of vital signs. If that not be the case, you're doing it every 15 minutes. And you're going to do that for approximately 2 hours, and then every hour, and then every 4 hours as the patient stabilizes. But you have to do it according to whatever the hospital protocol is. You're going to see that the person will be supplemented with oxygen, be careful with positioning, make sure they're medicated for pain. They may need mechanical ventilation longer than anticipated, and chest drainage. Anytime you break the pleura, either from an internal aspect, from the visceral membrane or from the parietal membrane, you need to place a chest tube, because negative pressure won't be maintained until you have that closed system back. You're going to monitor respiratory and cardiovascular status. You're going to hopefully see improving gas exchange. Hopefully you're going to see that pain management has worked, and you're going to promote mobility exercises and shoulder exercises as depending upon the position as to where the lung surgery was done. And then fluid and electrolytes, and then obviously monitor and manage the potential complications. A chest drainage system is a chest drainage system is a suction source, and it's a collection chamber for pleural drainage. Remember that the sole purpose of your underwater chest drainage system is to remove air and to restore negative pressure. To remove air and to and any kind of drainage, and to restore negative pressure. The idea, that slide is out of sequence. The idea of patient teaching, that goes with the surgery. So there you go. Okay. Now, in terms of chest tubes, you're looking at, once again, the idea of the visceral membrane and then the parietal membrane. Space in between is your pleural space. And in regards to that pleural space, that's what maintains the negative pressure. So causes could be hemothorax, pneumothorax, air, blood, accordingly. Now, pneumothorax is basically when air gets into that pleural space. And there's two ways it can get in. It can get in by a closed pneumo, which means that the visceral membrane is broken. So you're going to say, how did that happen? Well, that usually happens when a fistula is formed from infection. Okay, that happens when a fistula is formed from infection. Open pneumothorax is when the parietal membrane is broken, and that's usually from some type of cut, whether it be surgical wound or it could be a stab wound. Or, I always think of this little old lady I took care of, and she was in her 80s, and she had this cameo, and when she was putting it on, she stuck herself. So she got the cameo on. She went to her daughter's wedding, and at the end of the wedding, she was starting to feel short of breath. Well, what had happened is that when she stuck herself, she was very thin, tiny lady. She stuck into that pleural membrane and subsequently caused an open pneumo. And, you know, so when she came into the emergency room, they saw she had a pneumothorax, but could see the little point, and this is the story that she told. And this picture here shows you the idea of you see where the arrow is? That's where there's a region of the lungs, all right? And then he is where on our left, but on the patient's right, you'll see that there's no air in the lungs, so you're seeing an opacity there. So whenever you're looking at an X-ray, you're looking at you have to think of the X-ray as being opposite to what you're seeing. So this is the left side, even though it's your right, and this is your right side, even though it's the patient's right side, even though left. So it's always opposite how you're looking at it. Hemothorax is a buildup of blood, and this X-ray shows that. Now, tube placement is going to tell you what basically is draining. So you remember, air rises. So if air rises, you're going to have a higher placement of chest tube. If you're draining something, the chest tube is going to be lower. Now here is your underwater chest drainage system, all right? And basically what you have to have is an underwater seal. So, you know, in order to create an underwater seal, all you have to do is place if it's an emergency, you don't have an underwater system readily available, all you got to do is take the tubing and place it into bottled sterile water, or even at that moment in time. Create an underwater seal. Underwater seal.
Can you repeat that, Professor? We didn't hear that.
Yeah, we didn't hear any of that. You started breaking down, started talking about water seal chambers.
A water seal is a straw underwater. A straw underwater. So if you were in a situation where you didn't have an underwater seal available, you would this and place it into a bottle of sterile water or a bottle of sterile saline, okay? And you've created an underwater seal. So it's a straw underwater, okay? Now, there's a video that I have for the underwater drainage system, and it's on Blackboard. And if you guys could just take a look at that. Okay. Now, there's two types of chest tubes that you're going to see in the chest. You're going to see the pericardial one or the mediastinal one, and that's taking drainage from the pericardial sac. So that you'll see that for tamponade or post-op open heart surgery for drainage. The pleural one, you can use the sterile water or normal saline for the underwater seal, because first of all, it's not going to be there for that long. So you're going to it's only a very temporary measure in case of an emergency. But otherwise, you're right. Anytime you're looking at any kind of respiratory fluid used for respiratory, you're going to see sterile water utilized. Okay. So the type of chest tube that you're looking at with regards to respiratory is your pleural chest tube. Now, in terms of chest tube size for an adult, you're going to see a 28 to 32 French chest tube. When you measure French sizes with anything, not just chest tubes, usually Foley's also. But when you're using underwater, a chest drainage system or a chest tube for that, it's gonna, the smaller the number when you're measuring French, the smaller the number when measuring French, the narrower the lumen. So with 28 French is smaller than a 32 French. Okay. You're going to have your underwater chest drainage system, which in most instances nowadays is the atrium. You're going to also have your insertion tray, and this will be done under conscious sedation. The patient is actually going to feel the stab wound. So you have to sedate them because you're going to go through. You don't want to anesthetize the lung muscle tissue because then the person will stop breathing. But you're going to sedate them. And usually what the individual will tell you is if the chest tube is being placed and the person can communicate with you, is that, the relief for why you're putting the chest tube in, supersedes the actual initial pain, but it's minimized by sedation. Now, in terms of your chest tube, maintenance, what you want to see in terms of the tubing itself, the drainage tubing itself, is you want to see movement back and forth, all right? What they call tidling. So it's like a tidal wave. You're moving it back and forth, but you don't want to see bubbling in the underwater seal. You don't want to see bubbling in the underwater seal. If you see it bubbling in the underwater seal, that means that there's a leak in the system. If you see bubbling in the underwater seal, that means that there's a leak in the system. Okay? If you see bubbling, you're going to clamp the chest tube closest to the patient. If the bubbling stops, it's with the system. If the bubbling stops, it's with the patient. Sorry, correction. If the bubbling stops, it's with the patient. So you clamp close to the patient. The bubbling stops, it's with the patient. If the bubbling continues, it's with the system. Nowadays, if that's rarely the case, because of the fact that these systems are so, the plastic is so strong that you really can't, break it up like years ago when you had bottles. So, so in other words, if you see bubbling in the underwater seal here, if you see bubbling, you clamp close to the patient. If the bubbling stops, continues, it's with the system. You're also going to look to see that there's an occlusive dressing. So what does an occlusive dressing mean? An occlusive dressing means air cannot get in. Air cannot get in. Air could get out, but air cannot get in. So those transparent occlusive dressings, if you put it under a microscope, you'll see that it's like a one-way valve, so that air can't get in, but air could get out. Okay, so an occlusive dressing means air can't get into the site. Adhesive tape, not paper tape, if you don't have is occlusive in nature. Okay. Also, with regards to the occlusive dressing, you're also going to see some Vaseline gauze placed around the insertion site before you put on that occlusive dressing, sterile Vaseline gauze, so that it prevents any, it helps further seal that insertion point. And that dressing will stay in place for about 48 hours, or, unless somehow it loses its integrity, that you need to reinforce it. Now, in terms of monitoring the drainage, your primary care provider needs to tell you about what's acceptable for the drainage. Okay? So if you're post-op, they need to tell you 100 cc's an hour times 4 hours is okay or not okay. But they have to tell you what the parameters are for you to report it to them. You're also going to talk about, what does it look like? Is it bloody? Is it serous sanguinous? Is it purulent? Now, chest tubes don't stay in you forever. So what's the criteria for de-seeing a chest tube? Well, first of all, you need to make sure that you have a chest x-ray that shows good lung expansion, like you see in the x-ray that's next to the, it's on the slide. Okay? So you see how nice and, this heart's a little big, but the, how the lung feels, don't have opacity, that they're clear. That you have less than 75 cc worth of drainage within 24 hours. That they have good breath sounds, and that titling, has stopped because now the membrane has sealed over. What they're going to do, and nurses, are not generally credentialed to take out chest tubes. And not all physicians, and I should have qualified that, not all primary care providers are qualified to insert chest tubes or discontinue chest tubes. You have to be qualified, and you have to show competency in terms of that. And not just procedure, any procedure. So wherever you work, whatever agency you work in, as far as the primary care providers go, you're going to see a listing of skills that each individual primary care provider is competent to do. So generally speaking, a medical doctor is not going to be doing this, okay? So in terms of how a chest tube is going to be removed, so that you're aware of the procedure, you're going to first of all check to make sure the person is competent. What the person is going to do is they're going to inform the patient that they're going to be de-seeing the chest tube. So they're going to lay the patient flat because they don't want air to be sucked in. You're going to get ready for that for the primary care provider to place an occlusive dressing over the insertion site once the tube is out. So you're going to have the Vaseline gauze and the occlusive dressing ready. All right. So the primary care provider is going to tell the person to take a deep breath and hold it. Then they're going to take out the chest tube and immediately place the Vaseline gauze and the occlusive dressing on it. That dressing will stay in place for about 48 hours in order for that tissue to approximate. And then you're going to, at that point, you could change the dressing again. And that's the end of of these set of slides. So the next set of slides that we're going to look at is going to be the chronic chronic pulmonary disease.
Professor,
Yeah.
before we move on, can you tell us about the test tube maintenance, about bubbling? Is this never gonna be bubbling, or with some systems it's gonna be like
It shouldn't bubble. Now
Ever.
it shouldn't bubble. Now in the underwater seal, when you look at that video that I placed on the blackboard, there's an old system known as the Pleurovac. The problem with the Pleurovac is that its suction control chamber had water in it as well. And if you knocked it over, you could also lose the underwater seal. The Atrium is a newer system, and it works. It basically, the suction control is dry, and that's the system that most hospitals that I'm aware of utilizes, because also the technology of it is as if you knock it over, you don't lose the underwater seal.
So we
And it's
I just want to ask, so basically we need to know just water seal, right?
The water seal is what you need to be aware of, and you need to be monitoring. And you want to make sure that there's no bubbling in the underwater seal. If there is, as I think I mentioned earlier, you clamp close to the patient. If the bubbling stops, problem with the patient. And that could be that they developed a fistula, and and you have a closed pneumo from that. And if the bubbling continues, then it's a problem with the system. Maybe somebody nicked the tubing by mistake. Maybe it's not a tight fit of the connection. Maybe somebody cracked the underwater system.
Gotcha. Thank you so much.
Yeah, no, it's okay. So and like I said, it's very unlikely that you're going to see it damaged, because you have to. Well, I shouldn't say that, because when you're transporting patients in a hurry, somebody may crack it. Okay.
Thank you.
In terms of clamping a chest tube, you're only clamping a chest tube diagnostically to see where the problem is. It's not that you need an order to do that. And we don't clamp chest tubes anymore, meaning we don't clamp chest tubes on a continuous basis. All right. Sometimes, and I should qualify that, sometimes the surgeon clamps the chest tube, then does the chest X-ray to see statuses of the patient's lungs. But generally speaking, for any extended period of time, we don't clamp a chest tube. We don't clamp a chest tube for ambulation, et cetera, et cetera. Okay?
Okay, thank you.
All right, sure. Can everybody see this set of slides now that says management of a patient with chronic pulmonary disease?
Yes.